Hi, my name is Dr. Miguel Vidal, and this is my practice inspiration. My topic for today is the role of the immediate provisionalization in implant treatment. I live and work in Boston, Massachusetts, where I am a private practitioner, and I also lecture and teach in the Graduate Prosthodontic Clinic at the Harvard School of Dental Medicine. What I want to accomplish in today's talk is begin by reviewing the importance of implant positioning from a surgical standpoint and how that influences our aesthetic outcomes. We also want to define some different loading protocols that we have available to us. And we'll also discuss the influence of the implant abutment contours and how the provisional factors into that. And lastly, we'll present different implant provisionalization scenarios that we'll come across on a daily practice. So when our patients first present to us in situations like this, it's important to come up with an accurate diagnosis so that we can formulate our treatment plan for this particular patient. In this case, this patient suffered from bulimia for a number of years, and you can see the destruction on the teeth, and she lost vertical dimension of occlusion, and unfortunately is going to lose several teeth. And we're going to restore her with a combination of crowns, implants, and veneers, and altering and increasing the vertical dimension of occlusion. So once the implants are placed, we then place our provisionals to help contour and scallop the soft tissue profile so that we can restore this patient with a full mouth rehabilitation, as you see here, with a nice functional and aesthetic outcome for this patient. So how do we do that? Well, there's some keys to implants in the anterior aesthetic zone that I want to highlight for us. The first one would be the thickness of the labial plate bone. In this case, we know we want to have at least 2 millimeters of thickness of the facial plate of bone. As we know from several studies, most patients don't have that, so bone grafting is often going to be involved for these patients. The second key is the thickness of the labial gingiva, and here also a 2 millimeter thickness is advantageous, as we know from several studies, and most patients will also need to have some form of soft tissue grafting as well. And the third key would be the height of the interproximal bone and how it relates to the interdental papilla and the absence or presence of that papilla. When we talk about the surgical positioning of the implant, we need to evaluate 3 different planes. The first one would be the mesial distal plane. In this case, we want to stay at least 1.5 millimeters away from the body of the implant to the root of the neighboring tooth. The more we encroach on that space, the more we increase our risk of losing bone on the aspect of that natural tooth, and then the papilla will leave with that area. From a buccolingual standpoint, here this will depend on the type of restoration that you choose. A screw-retained restoration, we want to be more in the cingulum area, whereas a cement-retained restoration, you want to be slightly behind the incisal edge of the planned tooth. And the last one from a surgical positioning is the apical coronal standpoint, and here we want to be at least 3 millimeters apical to the planned gingival margin of our restoration. And that should give us the running room that we need to create the proper emergence profile for our implant crown. When we talk about an immediate implant, the positioning is slightly different, as you see here in the sagittal view. The implant needs to go on the palatal wall and hug that bone and stay away from the facial plate of bone, and you can see how thin it is in these scenarios. So that's going to leave a space or a gap that we're going to graft with bone to support that area. You can see on the successive photos here, slight deviations in the angulation of our immediate implant, how it influences and affects potentially the buccal plate of bone, and also changes dramatically the abutment and crown contours for our restoration. So we're going to use the 3A 2B rule as our guide on how to position implants in the anterior area. And this simply means 3 millimeters apical from the planned gingival margin of our restoration and 2 millimeters of thickness from the facial plate of bone to the body of the implant. So in a scenario like this, where the planned gingival margin of our restoration is there on the thermoplastic index, the bone is right in that area, so we cannot place our implant there. We had to reduce the bone 3 millimeters and then place the implant at that position. Without that, we don't have a chance to create the emergence profile. So let's define some of the loading protocols that are available to us when we're talking about implants. So anything involving immediate loading, placement and loading, needs to be done within about a 48-hour period. An early loading protocol then will refer to a 48-hour up to 3 months time period. And a conventional loading protocol will be anywhere from 3 to 6 months of healing time. And delayed will be anything plus 6 months. So let's look at our patients that we're going to be doing direct provisionals in healed sites once the implant is placed. And here we have a patient with a healing abutment. The implant is just placed. we're going to go ahead and place our temporary abutment, as you see here. This is made out of titanium, and we can modify it clinically in the mouth or at chair side. And this is the workhorse for what I do for my provisionals using a titanium temporary abutment. I like the retention elements for the buildups. It really grabs onto it, and it's very strong and predictable for the restorations that we're using. There is a peak plastic component, but I find the titanium is much more predictable for what I'm trying to achieve. They do impart some grayness sometimes depending on the angulation of the implant, but that can be masked out in the laboratory or clinically by using some masking material. So going back to our clinical situation, we're going to go ahead and place our temporary abutment and use the patient's own provisional and hollow grind it and pick it up intraorally with restorative material. And you can see here from a lingual view the amount of material that we need to flow subgingivally to really create the contours for this crown, as you're going to see here, and a properly placed and screw-retained implant provisional. And here's the provisionals placed, and now we're going to allow the tissue to heal, and this is how the same patient will present about 4 months later, and let the tissue mature and create the natural contours that we see with the central incisor tooth number 8. So once we're ready to make our impression, we go ahead and design our abutment with whatever material we want, and we make it to support the soft tissue that we've created and to mimic also the natural tooth preparation on tooth number 8 for more symmetry with the crowns. Then we turn it over to our technician, and they go ahead and fabricate our 3 ceramic crowns, and then we can rehabilitate this patient from his trauma scenario to the 3 teeth in the area. So now we're going to talk about making provisionals indirectly on healed ridges, and this is where we take an implant level impression and work on it in the laboratory. And here, together with our technician, we're going to outline what we want our emergence profile to be, and then modify the soft tissue moulage to predict where this tissue is going to end up. We're going to go ahead and place our temporary abutment, as you see here, modify it on the lingual aspect for the screw hole, go ahead and sandblast it, apply the cement, and cement our CAD/CAM provisional onto this as a unit. And this is how it's going to look. And I want to show you the apical aspect. You can see how thin it is until it becomes right about 1 millimeter to 1.5 millimeters at the gingival aspect, and that's where we start contouring and creating the bulk in the critical aspect to drive up that tissue. And from different views, you can see how a nicely contoured provisional needs to be done. Then we're going to go from our working cast to seated, so you can see how the tissue will be supported in this area, and a screw-retained aspect on the lingual. So when we talk about implant abutment crown contours, we want to start with a flatter profile and evaluate our tissue contours at 4-week intervals. Let's spend some time here talking about the critical and subcritical contours. Very important topic. So the critical contours will refer to the part of the crown that goes slightly subgingival and where the abutment starts. The subcritical contour will refer to the abutment, all the part of the abutment onto the platform of the implant. Modifying each of these changes our soft tissue profile differently. So, for instance, if we wanted to make our gingival margin go more coronal or bring it down, we modify the critical contour and flatten that, and then the soft tissue will come down. Conversely, if we want to drive the tissue up apically, we then add bulk to our critical contour, and the soft tissue will go higher. When we look at the subcritical contour, that has a different influence on our peri-implant mucosa. If we want to try to drive some of the papilla here, in this case on the mesial, we're going to add subcritically to this area on the mesial and create more convexity to the area to try to push that papilla in there. If we try to do that with the critical contour only, that's going to create a more square tooth shape that won't be symmetrical and the proper shape with the contralateral central incisor. So now we're going to talk about doing direct provisionals in immediate extraction sites. So we have a patient that presents like this with a tooth that is non-restorable and fractured in 3 different places. So we have the option of doing immediate placement and immediate loading. And the advantage that I see for my patients and myself is really the improved or maintenance of the soft tissue adaptation for these patients. For guidelines of immediate loading, I think the most critical that I just want to highlight here is initial stability. If you don't have initial stability, you should not load the implant. So in this particular case, we're going to place our temporary abutment, and I'm actually going to use the patient's own tooth and hollow it out and place it over the temporary abutment, and with flowable resin, pick up that temporary abutment directly in the mouth. and then flow in our material to create, again, the subcritical and critical contours we just talked about to support the soft tissue. And this is how the patient looks the day of the procedure and goes home with their own tooth as the temporary. We can't always do that. For instance, going back to the trauma case I just started with, her tooth was fractured too much. So I had to use a denture tooth and use the same process to hollow grind it and pick it up intraorally. And here you can see the advantage of doing this treatment protocol, where we really maintain very nicely the contours of the patient's natural dentition if you like how their tissue presents. So then we can go ahead and deliver our single unit implant crown on tooth number 8 and have a nice emergence profile of this implant crown and blends in seamlessly with the natural dentition. And here we are at a 7-year follow-up showing a nice stable outcome for her. So let's spend some time talking about the implant abutment contours and how this impacts our provisionals. Well, we want to have ideally a connection that is a conical connection. Conical connections have been proven to be superior in relation to the micro gap or bacteria seal and the micro movement ability. And this all goes to function to lowering marginal bone loss in this area. The platform switch design, which is often incorporated into the conical design implants, also has been shown to move that micro gap away from the edge of the implant and internalize it, leading to more bone maintenance around these implants. We also like to have a concave emergence profile for our abutments that would help get extra soft tissue in the area and extra volume for the support of the bone in this area. Having an implant system that has a consistent profile all the way from the healing cap through every restorative material that we would use for this really is advantageous and gets a predictability from the moment we place our healing cap. So now we're going to talk about implants that we don't want to immediately load. And these are scenarios that we don't want to take the risk, but we still want to start forming the soft tissue the day the implant's placed. And we can do that with a different technology. So we can place our implants in a guided fashion, just like we normally do, and then have the company make a customized anatomic healing abutment, in this case out of titanium. And this is going to be placed the same day the implants are placed, and it's going to start sculpting the soft tissue for us in these areas with a nicely polished titanium. And this is based on the anatomy of the patient's own tooth. As you see here, overlapping it, that's how it's fabricated. And we can also make them out of pink acrylic, as you see here, and clinically this is how it will look while they heal. So then we can go back once the implants are ready to be loaded, place our temporary abutments and pick them up just like we showed, and fabricate our provisional as seen here. So the last category we're going to talk about is the digital or guided indirect provisionals for immediate placed implants. And this is going to be all digital, and everything is going to be made ahead of time according to our plan, including the provisional. So this is going to be the immediate loading protocol here. And this patient presents with an extremely high smile line and a fractured tooth number 8. So we're going to be very careful taking out this tooth and moving it mesiodistally to protect that facial plate of bone. We're going to go ahead and place our implant, and you can see a nicely positioned implant using guided technology. And we're going to fill that area as we've been trained with the proper bone grafting techniques and membranes. And then I'm going to attach my lab fabricated, digitally guided implant provisional with everything's going to be made as one unit ahead of time. And I simply need to place that in the mouth and make sure my critical and subcritical contours are not too bulky and make them flat. And this is how the patient leaves that day. We place the implant, and I show you how we are able to maintain that 2 millimeters of buccal plate to the body of the implant very precisely with digital guided surgery. And this is how the patient presents for her 2-week follow-up. In this case, everything's looking great. I have excess tissue because I created a flat profile. But now, when she heals, I can then train the tissue to go a little higher as I need to. And this is really the advantage of this treatment modality, preserving the architecture and the nice triangular shape that a central incisor should have. Because then we can go to our screw retain final restoration here, pushing the tissue up as you can see there, and then starting off how she started with the fracture, overlaying, and this is how she ended up with her nice implant crown in the area. So I've tried to show and highlight some of the options that we have with immediate provisionalizations and that functions to really get a predictable aesthetic outcome for our patients. I want to thank you for your attention. I hope you enjoyed the talk.